would like to call upon Dr. Cordelia Chan.
Rohit, on the lighter side, I want to ask Rupal, after she operated her husband, and she says he can see well. My question is, can he see her point of view?
Who is asking?
Who can it be?
Do you think any husband can not agree with any
No
wife's
choice.
point of view?
No choice.
What a question is this?
Please, thank you.
Hello? Okay, hello everyone. It's very nice to be here. Thank you, Dr. Rohit, for inviting me. Last year I was in Bangalore for barely 24 hours, but this year I have more time with all of you. So it's very nice to see all my friends and familiar faces here. So I'll be speaking to you on smile, okay? To smile or not to smile. Well, it's actually a favorite topic of mine, simply because I think this topic evokes a lot of emotions and a lot of debate whenever it is mentioned. Okay, so here are my financial disclosures, none of which are relevant to the talk today. I have a question for the audience, okay? So what is the corneal laser refractive procedure of choice in your practice?
Smile.
Okay, so for those of you who do surface ablation like PRK, trans-PRK, epi-LASIK, LASIK, show of hands, please. So that's your treatment of choice. Okay, so how about LASIK? You're supposed to answer only once. Damien has put up his hands twice. Now, I just won once, so we will start again. PRK, how many of you? Procedure of choice. Okay, how about LASIK? Of course, yes, but primarily the procedure of choice, the one that you do most. And how about SMILE? Okay, so it does seem that most people do LASIK. Okay, not surprising. I'll focus my talk on SMILE, so this is my technique. I think for those of you who know me well enough, know my views on SMILE, okay? But for those of you, I think most of you here don't know me very well, I think this talk is for you. It's, I think, very important for us to be objective, okay? And that's what I'm going to do. I'm going to give you the evidence that's out there, and at the end, I will reserve my comments and judgment about the procedure at the end of my talk. Okay, so just to give you an idea about my experience with refractive lenticule extraction, way back in 2010, when I was at the Singapore National Eye Centre, we started with FLEX. So FLEX is a full LASIK type flap procedure, for those of you who are not too familiar. And we use the femtosecond laser to fashion a LASIK-like flap, as well as the lenticule. There's no excimer laser involved. We lift the flap just like we do for LASIK, and then we physically remove the lenticule, so that's FLEX. Now, we were not privy to the SMILE software till 2012. So in the interim period, what we did was pseudo-SMILE. So pseudo-SMILE was a way to practice this method of lenticule dissection and extraction. So this is actually, again, a full LASIK type flap, but instead of lifting the whole flap, we fashion a little pocket about 5-6 millimeters, and through this pocket, we actually do the dissection of the lenticule and extract the lenticule. Should we run into problems, which we do, because there is a learning curve, we could always convert it to a full LASIK procedure and complete the procedure. And in 2012, we were then, the SMILE software was made available, and so we started doing our clinical trial at Singapore National Eye Centre. Okay, so how good is SMILE? So we're going to look at the evidence now, in particular, in terms of dry eye, biomechanics, visual outcomes, regression, as well as visual recovery. Now, when we talk about dry eye, it's very important to look at cornea innervation and sensitivity, especially if you're looking at a cornea-based procedure. Just to recap, all these corneal nerve fibers come from the periphery, they go radially in to the stroma, and then they branch vertically through Bowman's membrane, and then they form the subbasal nerve plexus. And this is important in the lacrimal function unit in tear secretion. So as you can see in SMILE, the cut is just very small. These radial fibers are cut just about 2.5 to 3 millimeters. And femtosecond LASIK, it is all around. So in theory, SMILE should cause much less dry eye than LASIK. So here's the evidence, some of the studies that have been carried out. To cut a long story short, SMILE and LASIK both cause dry eye. However, SMILE affords a faster recovery in the first 3 months, but at the end of 6 months, everything evens out, there's no difference. Okay, so that's important. Now let's look at biomechanics next. So we do know that the anterior 40% of the cornea stroma is the strongest, and it is these vertical cuts rather than the horizontal lamellar cuts that actually induce the biomechanical weakening. So for LASIK, there's the cut all around, which means most of the anterior stroma is cut, and for SMILE, it's just a small portion that is cut, and most is uncut. So by this, SMILE theoretically should have less biomechanical weakening. So what do the studies on ORA show? The studies show that both LASIK and SMILE show biomechanical weakening, but in terms of CRF and CH, there's no difference. And there's this study that shows that only in treatments more than 6 diopters does SMILE have a biomechanical, less biomechanical weakening than LASIK. Okay, so for anything less than 6 diopters, the lower treatments, there's no biomechanical difference. There are newer studies which show some difference in SMILE, giving SMILE a biomechanical advantage, but they are mainly theoretical, and I'm talking about studies using finite element 3D computer models as well as the mathematical model that Dan Reinstein has described. Okay, so in terms of keratosis, here's the list of all the published studies on keratosis after SMILE. I'm sure there are more, but generally it tells us that SMILE ectasia can still occur, and that's why most of us follow similar stringent topographic and pachymetric criteria for, as we do for LASIK. Okay, looking at visual outcomes for low myopes, studies have shown that results for SMILE are good, but I think for those of you who do SMILE, you do know that for the lower treatments, the lenticule can be thin. For novice surgeons, it can be a bit tricky to get the lenticule out. There are some studies reporting less favorable outcomes which could be related to learning curve issues. For high myopia, most studies show LASIK and SMILE have similar efficacy, predictability, and safety. In terms of higher order aberrations, there are some studies that show that perhaps SMILE gives a better quality of vision. And with astigmatism, that's where a bit more controversy lies. I think many studies have shown that there have been some suboptimal results of SMILE for astigmatic corrections, and generally there's a bit of an undercorrection with the rule astigmatism, and there are studies showing that SMILE and LASIK, when you look at astigmatism, LASIK gives better outcomes. Fortunately, there's a manual way to circumvent this problem. Dr. Sri Ganesh has described very nicely this manual technique of marking the two, the 0 and 180 degrees when the patient is sitting up, and when you are doing the procedure, when suction is on, you manually rotate the cone to match it to the horizontal axis of the reticule, and this, I think most of us would do it for corrections of 1 diopter or more, and this has more or less circumvented the problem of the lack of this cyclotorsion compensation of the VisuMax platform. Okay, let's look at regression next. We do know that regression is related to epithelial healing and modulation and hyperplasia. So LASIK has had a very long track record, so there are many studies looking at regression over a long term. So this study from Spain shows that at 10 years, about minus 1.5 diopter regression, and at 15 years, slightly more. The thing about SMILE regression studies is that we do not have more than 5-year data. Okay, so but looking at the trend, you can see that there is some regression, but probably not very much. At 5 years, it's about 0.5 diopters. And this study, over 3 years, shows that SMILE possibly has less regression than LASIK over time. Okay, but so we can safely conclude that SMILE achieves more stable long-term refractive outcome based on what we have right now, but certainly long-term studies are needed. Okay, so I'm going to spend more time on this because I think this is probably the most important aspect of SMILE that's, it's a hot topic of discussion, and it's really the elephant in the room for all those of you who like SMILE very much, the concept of visual recovery. Okay, so I'm going to take you back in time to 2012, 2013. at, when we were first doing SMILE at the Singapore National Eye Centre. So these are unpublished results. At SNEC, we audit all our cases, and we were looking at our SMILE results, and we were a little puzzled why our patients weren't that happy. Okay, so if you look at LASIK at 3 months, you have an efficacy index of 0.98, and with SMILE, 0.91, and it was statistically significant difference. Only at 6 months did SMILE catch up with LASIK. Okay, so anecdotally, we were looking at our own patients, and I could tell that my patients after SMILE weren't as happy at 1 day, 1 week, and at 1 month compared to my LASIK patients. Okay, so why was this so? We also noticed that we were having sticky dissections. So when we went to all these Carl Zeiss Meditech users meetings, we were looking at Rupal Shah and Sri Ganesh's videos, and we were noticing that the dissections were smooth and the lenticule came out so nicely. And I think I remember Rupal telling me, Cordelia, you better go look at your VisuMax machine. There's something not right. Your dissections are extremely sticky. Okay, so, and then there was this query of whether it was technique and surgeon dependent, which was affecting our results. That time, the 2 principal SMILE surgeons were Donald Tan and myself, and we are cornea surgeons who do DALT and dissect, and certainly those were more technically challenging procedures, and we did not have any problems with SMILE. So it's not technique or surgeon dependent. And eventually what happened was we had our VisuMax laser replaced. We tried changing the settings, optimizing the energy levels, etc. But no matter what we did, there was still no improvement in the SMILE results. So the whole laser unit was replaced, and things are better now, although not really optimal. Okay, so subsequently, all these publications on delayed visual recovery of SMILE came out. So we realized that we are not alone, okay, in this. And finally, not long ago, SNEC came up with this publication, which was a prospective paired eye randomized study, 1 eye SMILE, 1 eye LASIK. And although this publication, the main aim was to actually describe intraoperative patient experiences, I believe that the most pertinent result in this publication was that it showed that blurring at 1 month was worse after SMILE than LASIK, and only at 3 months were they comparable. All right, so there are many postulated mechanisms on how visual recovery can be affected in SMILE, but generally I think more or less most of us would agree that SMILE visual recovery lags behind LASIK by about 1 month. Okay, so let's digress a bit and look at the LASIK flap. SMILE has always been, the selling point is, it's a flapless procedure, so you'll end up not having flap striae in the early post-op period or subsequently after trauma. And it allows patients to get back to an active lifestyle faster. These are very valid points. I mean, I usually tell my LASIK patients not to engage in, contact sports for at least 3 weeks a month, whereas for SMILE, they can get back to it very much faster. But in reality, how common is flap dislodgement nowadays? We are looking at using the femtosecond laser more than the microkeratome. I think most of us have more or less moved away from the microkeratome. And you have better flap stability because of the side cut angulation, the stromal healing. And I think there are many studies to show that post-op flap dislodgement is much less nowadays. So this thing about having a flap dislodge is not so much of an issue as compared to before. And I believe a flap is actually useful by the fact that you can lift up the flap and expose the stroma to the excimer laser, which at this point in time, their current profiles are smoother and more precise than any femtosecond laser that can achieve, okay? And that's why our LASIK patients recover faster. Okay, so the big question, should we continue to SMILE? Okay, I think the answer is yes, okay? It is a safe and effective procedure. Results have been excellent in some centers. In fact, SMILE is a useful marketing tool in a stagnating refractive surgery climate. I'm sure those of you who do SMILE, you use SMILE to promote your practice, to bring patients into the center. I think that's what many of us do. And I think, like I mentioned earlier, it's good for patients involved in high-impact contact sports who want to get back to their active lifestyle quicker. And I think the evidence shows that possibly there is less regression than LASIK for higher treatments, okay? But there's a big but here. I am very bothered by this delay in visual recovery. I hate it when my patients are unhappy at 1 day and 1 week. Okay, so, and Singaporeans are very fussy patients and they are difficult to manage generally. Okay, so I think this is the biggest bugbear of SMILE, which is why I'm tending not to do so much SMILE nowadays. There's definitely a less wow factor. And if I should do SMILE, I always choose my patients carefully and counsel them to lower their expectations for the first 1 month. Okay, and there's this other thing about the variability of SMILE results. I think it is quite obvious that there's a difference in performance and outcomes between VisuMax units. For those of you who own more than one VisuMax machine, I am sure you can attest to the fact that some machines perform better than others. Okay, I think there are many very brilliant SMILE surgeons in our midst today, and I would love to hear from them after my talk. And this thing about, the VisuMax being very temperature and humidity dependent, I have used almost all the femtosecond lasers available in the market for LASIK. And I can tell you that the VisuMax is the most so-called unstable platform compared to the Intralace, FS200, the Zima. And sometimes when there are a lot of warm bodies in the operating theater with me, I'll find that my dissections can be a bit stickier, and then you have lots of OBL, and then people think I'm a bad surgeon, And then you have to constantly modify and optimize your laser settings. And sometimes, even when the lenticule is very easily removed, the surgeon is happy. The next day, you see a 6/6 or 20/20 vision in the chart, and the patient comes in frowning because they say it is still blur. Okay, so these are some of the things which, I experience. Now, this that's in the box here is actually my personal view, so don't take it as gospel truth. But I believe that how much a surgeon likes SMILE is very dependent on the performance of the VisuMax unit in their possession. Okay, so unfortunately in Singapore and SNEC, we started off on the wrong foot. There were some problems with the laser, and so SMILE has never really caught on in Singapore because of that. Okay, so the current reality, I think Carl Zeiss Meditech should be congratulated for coming up with this brilliant concept, and I think it is the future of refractive surgery. But then this issue of this delayed visual recovery needs to be addressed before SMILE can actually overtake and replace LASIK as the gold standard procedure of choice. And I think work should be focused on refining the current technology in terms of technical and clinical improvements and more stable and consistent femtosecond laser units. So what's the future? I think other companies, for example, Alcon, are already working on the ultraviolet femtosecond laser for lenticule creation, shorter wavelength, a lower pulse energy, and hopefully we can have more stable femtosecond laser units and smoother and more consistent dissections. Okay, so that's the end of my talk. You can befriend me on social media, on Facebook and Instagram. And for those of you who have never been to Singapore, please come and visit. Singapore is a very small country compared to India, but I think we have a lot to offer, and I think you'll like it there. Thank you very much. Do we have questions?
So, Cordelia here. So what is the parameter of the energy that you struggle with and then you increase, and if Shri Ganesh and Rupal can comment what energy parameters you use and how does that make difference as far as the sticky flap is concerned?
The energy parameters can be totally different for different machines. So you can never look at your friend's machine and set, right now we have 3 VisuMax. One has an energy setting optimal of 32, one is like 28 and another 26. So it's totally, so you can't use one parameter or a threshold in one machine into the other. You need to find the best threshold where you get no OBL, you get a very uniform bubble pattern and a smooth dissection.
So we started with 30, then we increased to 31. 32 in our machine is now giving us a good dissection.
Yeah, it is optimal because if you go too high, if you increase the energy, then you get OBL. If you reduce the energy too much, you get black spots and you have difficult dissection. So you have to have that sweet spot, the optimal threshold, and it is different for each machine. So you have to find that. And when you have that optimal threshold, like yesterday I showed a video, it's so easy to remove the lenticule. And the visual, most of our patients are better than 20/20 on day one. In fact, Dr. Ronald Gaster from the US is here for training with us. And he was saying that, why is it that everybody says that the visual recovery is delayed in SMILE? Because what I see is most of them are better than 20/20 day one. So if you have a procedure which is a flapless procedure, where you're getting most of your patients better than 20/20 on day one, then definitely you would prefer a flapless procedure, right, Cordelia?
I can understand that, but then there are some systems, some units where no matter what you do, okay, no matter how you refine or change the settings, it doesn't work very well. Okay, so that's
Yeah,
what.
but those are the older machines, and there were problems with the older machines.
Yes, the one of my laser also gave a lot of problems before we could actually set
Older
the
meaning?
parameters right.
Older meaning?
Older meaning 10 years old.
Older meaning as in the machines that
Generation.
were available at that point in time compared to one that is newly produced.
Yes, because the newer machines, I think they have a better energy adjustment.
So how many patients do you actually require to come to an optimal laser energy setting? You need to do some patients, correct?
Nowadays, not too many, because you can make out from
I
the
have a lot of
pattern
friends who
that
have
you
ended
get.
up with their first few patients having hyperopia, and probably they could
No,
not
the refractive result doesn't suffer.
Really?
Even
See,
with the
with-
200 hertz laser that we had,
And sometimes
everybody
See,
achieved
the
their best
difference-
corrected vision, so that was not
And
an
sometimes
The
you need
difference
to
with an
vary the
excimer
settings
and
within the
SMILE,
patient.
with an excimer, if you actually increase the fluence, you get an overcorrection. If you reduce the fluence, you get an undercorrection.
Here the
With
predictability is totally on the spot.
SMILE, if you increase the fluence, you don't get an overcorrection, you get more scatter from the interface. So that's the difference.
So I think from this discussion that's going on right now, you can tell it is quite obvious that for SMILE, you need to play around with your settings. Very much so, compared to LASIK and the excimer laser, which is quite idiot-proof in a way. You
No,
know,
it's
and it's
not.
very consistent.
It's not that constant playing around of fluence levels is necessary. I think SMILE is one procedure which has introduced some amount of surgical aspect to refractive surgery. And definitely it takes 50-100 eyes to stabilize and get your process right. And initially, when we started out, it was 34 energy. Now we have slowly dropped it down to 28. As Sri Ganesh said, each machine has its own consistency. But having achieved it, I think today, most normal cases on post-operative day one is doing quite well. I do fair amount of femtolasic also, and I find that the results are quite comparable. It just takes you a certain amount of time to reach that. I just noticed that in your presentation, all your SMILE numbers were about 100 eyes. And obviously you might have done more, but unless there's maybe a few more might have just, not the surgical procedure, but getting everything, putting all the pieces together would have given you better results.
Yes, I agree. I mean, SMILE has a big role in our refractive, surgery world today. And I do agree with what you have mentioned. But I think it also depends on the patient, okay, and your patient expectations. That's very, very important. I think you need to tell your patient that in the long term, they are going to be happy. There will be some, okay, who are not as happy in the first 1 day or 1 week. There will be, okay, and it depends on whether that patient can accept it. Okay, so I mean that's the biggest problem I think with SMILE in terms of the visual recovery. Other than that, long-term results shows that very stable and good outcomes.
When you are talking about the femtolaser, does it cause any kind of inflammation?
I'm sorry, I'm not sure where the question is coming from.
No, yeah.
Yeah, maybe you
So
could
when we are
stand.
talking about a lot of delayed healing, does femtolaser inflammation cause a role? Is there a role of immunomodulator drugs which are given for a long time, say for 3 months? Does it have a role? And
Well, I don't
inflammation?
think. I mean, the mechanisms for a delayed visual recovery, there are several factors. This thing about stromal remodeling and inflammation in the interface is postulated to be one of the mechanisms. However, to actually put the patient on immunomodulatory drugs for a long period, I don't think it is necessary. This delay that we're looking at is possibly at about a 1 week, 1 day or 1 week, okay? And I mean, to start them on, we all give our patients topical steroids, okay? So what kind of immunomodulation are you referring to, apart from that?
Talking about cyclosporin, which is usually a
Okay, but
protocol given
cyclosporin
for
doesn't
3
work
months.
immediately. It takes about 2 to 3 weeks for the effect to show. So we're looking at a first POD, first 1 week post-op visual recovery. I don't think cyclosporin is going to help very well. If anything, we should increase our topical steroids. So is that something that you do?
I think Rohit has done a study on inflammation between LASIK, PRK and SMILE, and they found that the least amount of inflammation is in SMILE
In SMILE.
and the maximum
But
in
it was
PRK.
done even in Singapore,
I hate to
where they
break
compared in rabbit's eye both LASIK
Yes.
versus
Even
SMILE.
in- yeah.
And your own study shows less inflammation in SMILE as compared to femto-LASIK. Study done at your place.
I'm sorry?
SNEC has done a study. I think
SNSC has
John has
done
done
a
a study
study
on
where,
inflammation.
on rabbit's eye, where they compared one eye femto-LASIK with the other eye SMILE.
Yes.
And the inflammation that was induced in those eyes. And they showed the SMILE eyes to be having less inflammation, even as compared to femto-LASIK eyes.
on
Yes.
that.
So, which means that inflammation is not the only factor involved in this delay
And
in
in fact,
the
we
visual
don't
recovery.
increase the steroids. We give for 5 days 4 times, and for another 5 days 2 times, and that's it for most of our patients. We don't even do any special counseling because it's simply not required. So we don't tell them that their vision is going to be delayed for a week or so because it simply doesn't happen. Most patients reach their best corrected vision right from very next day.
Dr. Rupal, on that note, in fact, I hate to break the preamble. We have some discussion on the SMILE session on these talks.